Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by Axome. The Epworth Sleepiness Scale is a staple in sleep clinics. It is something we have our patients fill out for every visit and is deeply rooted in sleep practices. We can all acknowledge that it is flawed and not always helpful. PAP adherence is another metric we use for every patient on PAP therapy and is part of the Medicare Merit-Based Incentive Payment System, or MIPS. Neither of these metrics captures the depth or breadth of the patient's experience. During his AASM presidency, Dr. Doug Kirsch wanted to come up with a better metric to capture other domains of symptom improvement. An expert advisory panel was convened and recently published a new scale called PLATO. Dr. Kirsch is the medical director of Atrium Health Sleep Medicine. He is currently a clinical professor in the Department of Neurology at the Wake Forest School of Medicine. Dr. Fariha Abbasi-Feinberg is the president-elect of the AASM and is in private practice in Fort Myers, Florida, as part of Millennium Physician Group. They are here today to walk us through this new longitudinal assessment tool. Welcome. Thanks for being here.
Thank you for having us, Seema. I've always been a big fan of your show and of your podcast, so thank you.
That's very sweet. So, Doug, let's start with you. What is PLATO?
So, Seema, again, thanks for having us on. PLATO is a new 11-question tool that we hope is going to become a staple for everybody's sleep medicine practice. And it starts a long time ago, back when Medicare deemed that PAP adherence was necessary for getting a CPAP machine, or keeping your CPAP machine for that matter. And at that point, the AASM was pretty concerned about this. This was not something that any other medical treatment required, the show use of that treatment. And so this began a long, winding road that has led us to PLATO today.
What does PLATO stand for?
So PLATO stands for Patient-Reported Longitudinal Assessment Tool, for OSA.
And so it's only for OSA then, obviously, right?
This is for OSA, patients who are being treated for OSA. So this isn't a screening tool. This is a tool that is being used to assess patient symptoms over time. And it's not specific for any one sleep apnea treatment.
Okay. So what does it capture that the Epworth doesn't?
So the tool looks at sleepiness because we know that sleepiness is a core piece of sleep apnea as a symptom, but it's more than that. So if you look at the tool has several questions that look at aspects of tiredness, sleepiness, exhaustion, irritability, concentration, right? These aren't just about being sleepy. Sleepiness is one part of it, but it's sort of looking at those aspects as well. It does ask about, hey, did I nod off when I was sitting, or was it difficult to sort of stay awake in an activity? But it also asks about nighttime sleep, about snoring and difficulty staying asleep, and it asks about kind of sleep quality. And so we're trying to look at a little bit more broad aspect of some of the symptoms of sleep apnea.
So, I had asked Dr. Carol Rosen to be a guest, and she responded and she said, well, this was Doug's baby with a prolonged gestation. So it made me laugh, but I didn't really understand what she meant.
Right. So Carol, in her very lovely way, said that this started a long time ago, and I have been pushing for this project to come to completion over really since probably 2010 is where this conversations really began.
Oh, wow. Okay.
And over that time, there were several committees and task forces looking at things like alternative models for sleep care and what sort of could be part of a Medicare adherence rule that was beyond just adherence to CPAP, but also symptomatic improvement, since they were asking about methodologies. And it wasn't really until we did the AASM put together a task force to talk about what tools existed in sleep medicine, questionnaire tools for both screening and assessment of symptoms. And at that point, that committee came back with a paper that is available in the AASM that sort of says, hey, look, there are a lot of good tools out there, but there are problems with them. They're either too long, they are not freely available, they're owned by an academic institution, they're difficult to use. And so this is what really allowed us the freedom to say, okay, it's time to develop a new tool.
Oh, okay, so
Yeah.
this one isn't then owned by an academic institution?
No, exactly. Doug may have started to consider this in 2010, but for me, it really became an issue in around 2016. I don't know if you all remember, but in 2015, MACRA, MIPS, APMs became a thing. And all of a sudden, we were all looking at coming up with some type of a bundled code for evaluation of patients with sleep disordered breathing and their follow-ups. And it turned out that CMS required that to establish such a bundled code, you had some kind of quality measures. And, we picked some of the usual measures in terms of, is there severity noted? Was PAP prescribed? But in terms of outcome measures, we could look at the download, but we really had no good way to measure and track subjective outcomes. And so I think that was one instance where I realized that something needs to be developed for this. And then, I think Doug and the ASM had this task force looking at all these different possibilities to see if there were any other tools out there. And it turned out that they just did not fit the bill for us.
Oh, so that's interesting. So you kind of have to make sure that something doesn't already exist before you kind of start something new.
Right. And yeah, and there are quite a few different questionnaires that are out there. And some of them, focus on insomnia, some of them focus on quality of sleep, but they're really not specific for sleep apnea.
Okay. So how do you do this? Do you just all sit in a room and come up with questions, or how does this whole thing work?
So, Seema, that was my plan. My plan was to get a group of people in a room, because that's always how I'd always done things at the academy. Is
Yeah.
You get experts together in a room and you say, hey, let's come up with some good ways of doing this.
Yeah.
I was, while that was my idea, I was steered differently, because I think the thought was about this project that it was going to be a much more challenging one, not just in the conception of the tool, but also in the actual practicalities of how do you measure whether the tool works. And so
that makes sense. Yeah.
So that's where we needed to involve some experts in sleep, but also experts in tool design. And so the academy, the board of directors, once they approved this tool, went out to find some folks who could potentially help us build this tool. And in fact, there are companies that do this very thing. And so Icon was the team that was selected to kind of help us with this project.
Oh, so that's interesting. So that's their whole business then, is to come up with tools for medical problems.
Yeah, and it actually turns out that there's FDA guidance on developing and validating outcome measures.
Oh, no way.
And that's exactly the process that was followed. So it was a multi-phase mixed methods approach to come up with this questionnaire.
And so, are these the questions you started out with, or how did it all, or is this how kind of, did you end up with this? Obviously you ended up with this, but where did it start?
Yeah, so it started off with what are called concept elicitation interviews. And these are basically hour-long interviews that were being conducted with patients that had sleep apnea. And the interviewers just recorded the patient's experiences, and they asked them open-ended questions, which led to other questions. And we initially started off with 43 questions that we thought were going to be worthwhile.
Oh, wow.
Yeah. And so from there, It got trimmed down to about 31 questions. And during this time, there were some more cognitive interviews that were being done with folks. And from there, it got cut back a little bit more and more after each round of interviews to see how people responded to each item, if it made sense, if it was relevant, if it was suitable, and all that kind of stuff.
Why do you cut it back? Just because you had a goal of how many questions you wanted, or you wanted it shorter, or like, why does it have to be shorter? Just because it's easier?
Well, I think anybody who's had the experience of using an Epworth knows that 8 questions can be done by folks pretty quickly, and it doesn't take a lot of time in a clinical day for that to be done. And I think the issue with, say, something that's 43 questions is, it gives us an enormous amount of information about the patient's experience with symptoms and sleep apnea. But practically speaking, in a day when you're seeing 20 patients, that might be challenging for them to complete while they're there in the room or before they see you or whatever. So the idea is it had to be able to be completed in a relatively rapid fashion. And I think somewhere between 8 and 10 questions seemed like a reasonable goal to get to.
In the journey from 43 questions to 20-something to 11, I imagine there was a lot of negotiation. So tell me about that.
Yeah, so, we started off with a good 31 questions that seemed very comprehensive.
Okay.
And from there, we were able to whittle it down to 22 questions. And at that point, we had a fantastic questionnaire. It was very complete. It included pretty much everything that you would want to ask. But it was 22 questions. It was just too long and not really convenient for someone to do in private practice.
And so that's what brought it, then you pushed to get it to 11?
This is where the expert advisory panel came in to really sort of look at both the quality that the questions were asking about and using the ICON psychometric data to kind of make a decision on which were the best questions and which were the most clinically relevant questions, right? Because those two things had to align reasonably well together to get you to a tool that we believe should be about 10 questions. That seemed to be about what most people would be willing to do in a daily busy clinical practice. And so that's how we ended up from 22 to 11, is by slowly dicing out some of those questions from 22 to 11.
And so that's why Nocturia didn't make the list.
Nocturia was one of the last ones to get cut.
Yeah, there was some good arguing going on back and forth and negotiations going on. But in the end, the psychometric validation won out.
I am surprised that ED wasn't one of the questions.
So the first problem with ED, obviously, is that it only pertains to male patients mostly. So that becomes a difficult thing to have in a tool that theoretically should cross and be available to any patient.
But what about like libido?
We did have that on one of the questionnaires, but it was really difficult to validate that. I think it was vague, and we just didn't have good information on it.
So I have to tell you, when I was doing my internal medicine long-term assessment questions, on my 4th question, I had already had 2 on ED, and I got 1 right and 1 wrong. And so is the idea that we administer it to all patients or just the ones that we know have sleep apnea? Because where my mind is going is that if you do it like the first time you see them, like how do you even know if they have sleep apnea?
Yeah, that's a good question. But, typically when we walk in and start talking to a patient or we look at the referral, we have a suspicion that this person may have a high risk of sleep apnea. And so the plan should be to utilize it in folks if you have the high suspicion, and then track them as they go through the process of being treated, and then hopefully at their follow-ups. I think we are still figuring out how to incorporate it into a regular sleep practice on a regular basis. And I think we'll have to come up with some, best methodology for that.
And so what are we looking for? Like improvement in symptoms? Like does adherence factor into this too?
Well, I think adherence to PAP therapy in that particular case, or any treatment really, is important regardless, but the tool is really designed to track patient symptoms. So the idea being that, when you see them initially or when they're getting tested initially, you could track their symptoms at that time and then demonstrate the change over time. And much like when we see with scores in the Epworth, when somebody is not sleeping well or not feeling particularly good or not using their CPAP, they may have a climb in their Epworth score. Well, the idea is similarly, we would be able to track this. But beyond that, it would also be looking at some of these other symptoms about their sleep that maybe isn't being picked up on by the Epworth.
So then let's talk about the questions. Like, how are the questions framed?
Yeah, so the questions are divided into daytime symptoms, and then nighttime symptoms, and then sort of a general question about how was your sleep, right? So the daytime symptoms ask, in the past 7 days, how often do you experience the following during the day? And we reviewed how to phrase that exactly, but this is how it came up. And so the questions are such as, I felt tired, or I felt sleepy, or I felt exhausted, and there's a couple of other ones that are for the day. And those are the ones that we then score. The nighttime questions ask things like, as Doug mentioned earlier, I was told that I snored or I had difficulty staying asleep, which encompasses more than just snoring, right? Were they disrupted from other things? And then the final question is, in the past 7 nights, how do you rate your sleep quality? And it goes from a scale of 0 to 10. And, they just get to pick a number and see how it is.
So let's take a short break, and when we come back, we'll talk more about PLATO, the new longitudinal OSA assessment tool. You're listening to Talking Sleep from the American Academy of Sleep Medicine. Welcome back to Talking Sleep. We're talking with Dr. Kirsch and Dr. Abbasi-Feinberg about a new longitudinal assessment tool for obstructive sleep apnea. So some of the questions seem kind of similar. Like, Doug, you mentioned a few of them earlier. And they all kind of get to sleepiness. So why do you have all three of them?
So I think that's a really fair question. I think this comes back to having experts helping us with tool design. So when we looked at the questions that we asked people, as Fariha said, we started with 43 of them. And so once we started asking lots of people these questions, we had to sort of track it against, well, what are the other questionnaires that are used and what do they track to? And so the questions being tired and sleepy and exhausted, those questions actually didn't mean the same thing to patients. And they didn't track exactly the same. They didn't measure exactly the same things. And so patients viewed those things as being different. So even though some people might say, well, isn't tired the same as sleepy, the same as exhausted? The answer from a patient perspective was no, that those facts actually were viewed differently and they answered the questions differently.
I think also this is hopefully more encompassing for women. We all know that women respond differently to the Epworth questionnaire. We have had the experience of seeing a woman who has severe obstructive sleep apnea, but she would never fall asleep during the day, right? She may have trouble functioning. She may make comments like, oh my gosh, I can barely make it through her day, but she doesn't doze off. If we ask her some of these other questions, like does she feel exhausted or irritable, or is it difficult for her to concentrate, I think we'll get a better measure of what's going on with her. And then hopefully we can document improvement for her as well in a way that we cannot with the Epworth score.
I love that. Okay, so this has been validated, correct? So tell me about that process.
Yeah, so this was a pretty long process. To go through the whole psychometric validation, we again worked with ICON, but then they worked with a group of people. Actually, they had a company that they worked with, and there was 560 patients with obstructive sleep apnea that were used to validate this. We also had 40 patients that did not have obstructive sleep apnea that took the same questions and answered them. And so the way this worked was we had them answer the questions at one point, then 2 weeks later, at another point, they filled them out again just to make sure that there was, intra-test reliability. And then 6 weeks after that second one, so 8 weeks from the first one, we had them answer the questions again with the assumption that their sleep apnea was treated somewhere between week 2 and week 8.
Oh, but
And
not between week 1 and week 2.
correct.
Ah, interesting. And so then there was good test-retest reliability?
There was good retest reliability, and then the questions were validated. And, at this point, we were still at the 31 questions. And then we looked at all of those and narrowed it down further, down to about 22 questions that we felt were very valid.
So, and what can you tell from the results?
Well, I think we can see that when people have taken the test from week 1 to week 2 or week 0 to week 2, that their results stayed pretty stable. Whatever they had been doing or not doing around their sleep apnea, they continued to be stable at that result. But when you jumped from week 2 to week 8, as we had selected people who were initiating treatment, we could see theoretically that they had been on that treatment, and we could see a change in the scores from pre-treatment to post-treatment. And that's really what you want from any tool, is that there is some change over time in between the same patient.
So can you discriminate between the different severities of sleep apnea with this tool?
I think that was not the intent of the tool, was to say, hey, we think that anybody who scores an X is going to have mild sleep apnea, or Y is going to be severe sleep apnea. That's not what the tool does. But what I think you can say is we looked at populations of patients who had mild sleep apnea, who had moderate sleep apnea, who had severe sleep apnea, at least by their report. And so we got to use the tool in a broad range of patients with sleep apnea.
Okay, that makes sense. So I have the PLATO up in front of me. How should I score it? How do I do this?
Yeah. So there is a handy dandy rubric that comes with it. So when you download the questionnaire, there's also a little scoring card that you basically get. And, it may look like it's complicated right now, but once you do it a few times, it makes perfect sense. So the scores for each question will be from 0 to 4.
Okay.
And you basically will add up all the scores. So the range of answers can be from 0 all the way up to 44.
Oh, okay. Okay, so looking at it, the first 2 sections have 5 options, but then the last one is out of 10. Why is that?
So this comes back to when the tool was designed and questions were being asked, people find it easier to answer sometimes that 0 to 10 set of questions when it comes particularly to quality measure. So as opposed to sort of a time measure, which most of the other questions are. So there had to be a conversion between that question that was asked as a sleep quality rating of 0 to 10 into the same sort of weight of scoring. And so that's kind of what was done here. You just have to know that if you score 0 to 1, it's going to be a 4. And if you score 9 to 10, it's going to be a 0 and in between.
And then you follow this as you follow the patient.
Correct.
Okay. And so when you guys did it, the last one was at 8 weeks. Is the intent, though, for us to continue to move forward and continue to follow patients utilizing this tool moving forward forever?
Yeah, I mean, absolutely. I think this is going to be the longitudinal assessment tool, right? So this should give us long-term way to check on patients, see how they're feeling, see how they're doing, see what we need to change for them. And so I think this is, this should be it.
So when I downloaded it, I got a link through the ASM website, but it took me to like this company. Why is that?
So when a tool is created, this is all things that I had to learn as well. You you do, in fact, have to copyright it to make sure that it can't be utilized in ways you don't necessarily expect. And because of that, and because of the requests that are going to start coming and have already come from countries outside the United States and from people who are interested in the tool, there needs to be a method of making sure that the tool is accessible to everybody who wants it, but also if they're going to use it in a way that is perhaps immediately non-standard, that there's a way of tracking that and making sure that there is an agreement about how that tool can be used. So for instance, the tool is going to be free for anybody who's doing clinical work, but it is not necessarily available to translate into other languages without an agreement with the AASM effectively. And MAPI is the process, the company that will help them do that. So I had somebody just the other day reach out from China about translating the tool. And I was like, that's fantastic. But I have no knowledge about how that would actually occur. But MAPI and the ICON team know how to what are the validation processes for that.
Oh, that's interesting. So it has to be validated in a different language.
Yeah. And what's really interesting, we do have it in Spanish, right? So we have it in English and Spanish. Yeah. So we have that for here. But yeah, eventually it would be great to have it validated in different languages. And I think it's interesting. I mean, I was looking earlier, the Epworth, for instance, has been validated in different languages, but they've had to change some of the verbiage to make it consistent with the cultural norms of that area. And so I found that really fascinating because, I wonder what's going to have to change to make this acceptable in China or Italy. And so it was kind of cool to see.
I did kind of wonder because, there's a lot of, I think, cultural beliefs around sleep and napping and sleepiness and admitting if you're sleepy and, and that whole thing. So that's really interesting. And so you kind of hinted at this about we should maybe use this as a tool. And Medicare says we need to have a tool, right? And so we have been using the Epworth. Do you think this will replace the Epworth?
I think the Epworth has its place for looking at certain things, of course. Okay. We've used it forever. But this is looking at different things. And I think for patients with sleep apnea, this is much more specific for that disorder. And hopefully this will be the long-term follow-up for them. Now, Medicare and a lot of insurance companies actually really like patient-reported outcome measures because providing for the patient is more than just taking care of their medical issue. It's really how does it affect their quality of life? And that is a quality metric that Medicare harps upon. And so I think if we can prove that this is a good way to track and follow, hopefully Medicare will accept it at some point.
Well, and to me, some of them are reminiscent of the Epworth. So, Doug, you earlier talked about the first 3 questions. I felt tired, I felt sleepy, I felt exhausted. And then number 4 is I felt irritable. Number 5 is morning headache. But then number 6 is nodded off in the middle of participating in an activity. And then 7 is nodded off when I was sitting quietly. So those last 2 to me kind of harken back to the Epworth a little bit, right?
Yes, I mean, I think that is in fact true. I'm going to add the last question on that daytime, which is it's difficult for me to concentrate, right? Yeah. So we're trying to pick up on not just, hey, I'm falling asleep. I think it's important that, and I think that the expert panel felt very strongly that we needed to ask specific questions about sleepiness. But it's the other stuff. It's the headaches, the irritability, the concentration, the exhaustion. These are things that you're not necessarily getting very well out of an Epworth.
And then section B is I was told that I snored and then I had difficulty staying asleep.
Yeah, so one of the things that we really thought should be included was a question about nocturia. Yes. Because, so many of us in clinical practice see patients coming in for nocturia, and then when we treat their sleep apnea, their nocturia gets better. And again, I think it was part of one of the phases of the questionnaires. It was there, but then as we, trimmed down the number of questions, that was one that was recommended to be taken out. And so I had difficulty staying asleep kind of encompasses it in some degree. It's sort of a generic question. I mean, you can answer that for whatever reason you're waking up. And so hopefully we still get to the gist of that.
Now, I think it's still important to say that, these questions, not all are specific only to sleep apnea, right? There are lots of reasons that people might have difficulty staying asleep or that they might have difficulty concentrating, right? That this is not only, these symptoms are not only from sleep apnea,
Sure.
but the idea is that we're trying to track them over time so that hey, in the last few times you answered this, you scored much lower, and this time you're scoring much higher. What's going on? What do we need to look at that explains why you are symptomatically worse today than you were 6 months ago?
Is there a threshold number? Like we know the Epworth threshold is 10. Is there a threshold for this?
I mean, I think that we're still in the early days of trying to figure that out. I think if you look at some of the data, there certainly were some basic ideas about where people started. But remember, we were talking about very large groups here. And so I think in the end, it's not going to be right off the bat, hey, if you score under 20, everything is cool. And if you score over 35, that things are going to be, are awful. But I think you have a sense that's kind of where some of this data is going to end up being.
Yeah, and one of the things that was pointed out is that a 15-point change was considered significant, right? So if somebody comes in and scores a 40, for instance, before we start intervention, and now they're at a 20, for instance, we can feel comfortable that they have improved in a clinically significant, manner. And so that was something that the ICON folks helped us with. But, I think I would really like to put a plug in at this point, because this is just the start of PLATO, right? I mean, yes, it's been a long story getting here, but this is just the start. And so I would strongly recommend that people start utilizing it, that institutions, you use it, and we see what kind of data we get long-term. And I would recommend that people apply for a strategic research grant through the AASM Foundation so that we can put this out there in the real wild world of sleep medicine and, see what kind of information we come back with.
And Seema, to your question, when to give it, I mean, Fariha mentions you can give it certainly in the first clinical visit if you think strongly that this person might have sleep apnea. But there are other places you might be able to capture these people. So you might be able to capture them when you give them their home test, right? When they do a home sleep apnea test, often they have to complete a tool or some sort of intake for that. This is a good place to ask that because you have a pretty strong suspicion that these people are going to be tested for sleep apnea. Or in the laboratory, when they come in, often they're completing some paperwork. This is a good place to potentially integrate this early on. And then you can begin to measure it in practice once you've decided, yes, in fact, they have sleep apnea and we're going to track them with this over time.
Oh, that's a good idea. I like that.
It's also important to recognize, we talked a lot about CPAP, and that was sort of the genesis of this, but this could be used for treatment of sleep apnea by any cause, right? It could be treated based on an oral appliance. It could be treated based on a hypoglossal nerve stimulator, or it could be treated based on a medication. So any of those things theoretically should make the change in the symptoms that we're looking for. And that may be where things get, where we actually learn a lot about the different treatments we use.
Oh, yeah. I like that it's treatment agnostic. I like that. 2025 marks the 50th anniversary of the AASM. Doug, would you like to introduce the 50th clip?
So Dr. David White was a mentor of mine in Boston. He was a past president of the American Academy of Sleep Medicine, a professor at Harvard, and the editor of Sleep for many years. So it gives me great pleasure to introduce Dr. David White.
We're not moving as fast as and progressing up. That reminds me of another story. I remember in 1995, I was giving a talk at an advanced sleep course in Adelaide, Australia. And they asked me to talk about the future of sleep medicine was my topic. And I made the comment, I just said, look, again, 1995, and I said, if CPAP is still the way we're treating sleep apnea in 20 years, we're going to be a failed field. We've got to get better. We've got to make progress. And Colin Sullivan, obviously the inventor of CPAP, stood up and he said, David, you're dead wrong. He says, in 20 years, CPAP will be as comfortable as glasses. And when I tell that story, I say, it turns out we're both wrong. Because here we are 27 years later, and CPAP is still the main way we're treating sleep apnea. And we're not a failed field, but it certainly isn't as comfortable as glasses, and I don't think it ever will be. But I mean, again, I was trying to push the field to get going faster and come up with new things. And now I'm working on trying to evolve drugs to treat sleep apnea, which I think would be a very exciting outcome if we could come out with something that really works well. So I guess if my departing comment would be, we got to go faster, and the AASM needs to push that.
Now back to our conversation. So do you think this will become something that is built into the electronic health record like Epic?
Yeah, so the point for this will be to do that. There is an electronic version that will be available. I think it's going to take a little bit of time and maybe a push from sleep specialists to ask for it to be built in. I don't know how it is where you all are, but in my practice, putting something new in, I get put on a list of we'll get to it when, and so we'll have to decide when I ask for it.
You gotta find your moment.
Yep, exactly. But that's the plan. We have other questionnaires like the Stop Bang and the Epworth that are integrated, and they're very easy for everyone to access and click through. And so hopefully, this will be the same way.
You said something, Doug, earlier about how you copyright it so that you can't translate it, but that also means you can't change the questions, right? Like you can't adjust the verbiage.
So the idea is, when I have come across, for instance, the Epworth in many of the EMRs that I've worked on, the language has sometimes been altered or changed. And in theory, the tool is validated based on all the language that is part of that tool. And so when you start changing things, the tool is no longer the same tool and it's no longer valid. So the idea here is, that you really want to make sure when you use this tool or any other tool that the language is very precise, that it was designed that way, right? And this is where, again, translations can be difficult because I don't know Spanish nearly well enough to say what the differences between sleepy and tired might be in terms of wording, but that's where it was doable because we have translated it and made sure that it is functional in Spanish, but in any other language too, that language really needs to be precise. And so you want to make sure that when you bring it into whatever form you're going to use it in, that the language is correct.
Well, because I remember when there was an article about, so they took Stop Bang and they turned it into Stop Bag because it was so hard to get the neck circumference. Do you remember that?
Yeah.
It's still an ongoing conversation in my clinic.
Right. And so does copywriting prevent people from just like swapping out questions or removing them?
Theoretically, yes. I mean, I think that when you take on the tool and you say agree to download the tool, you say, I agree that this tool is as it has been designed. And so you can't just kind of take parts of the questions or pieces of the tool and use only those pieces, at least as it's designed today. Obviously if the academy feels differently at some point in the future, things may change. As you said, will you ever swap a question? Well, the answer is not today, but if we learn that we should have done something differently, then of course any good scientific organization should look at the tool and say, yeah, do we need to relook at this stuff? But I will say the amount of work and time that it took to get this tool from beginning to end was a lot, and it required an enormous amount of work of a bunch of people at the academy, a bunch of people who volunteered their time to help us be on the advisory panel, and ICON's hard work. And so, it is one of these things that going back and trying to do things again or do it slightly differently, it's probably not a small amount of work.
Yeah, I didn't realize that until we had this conversation, how much work goes into creating a tool.
Yeah. And, I agree with Doug that we really do need to thank the rest of the team that was involved. But I'd really like to thank Doug for his leadership in all of this. I mean, he really was the one who started it, spearheaded it, pushed it along the way. And, we jokingly, half jokingly, thought that somehow this needed to be named after him. but,
The Dougie, I love it.
but we decided on PLATO as being a good name.
So let me ask you, the AHRQ report, they didn't look at sleepiness, right?
Yeah. So, again, this is another point in time where the realization that we didn't have a good way to measure patient outcome metrics was emphasized for us at the academy.
Yeah.
I think as Doug mentioned, this started way, way back. And along the way, there was some question and discussion about, do we really need to do this? We're spending a lot of time on this. We're spending, not a small amount of money on this. Should we just shut it down? But when the AHRQ came out, I think that sort of emphasized to us that we need meaningful patient-reported outcome measures that show the value of what we provide for patients in treating their sleep apnea.
Yeah, because I kind of wonder if this will demonstrate that what we do matters, right? More than just sort of this focus on reducing cardiovascular outcomes. Like treating sleepiness is important.
Yeah, I think when that report came out, we all had certain feelings, right?
We had feelings, we did.
We did. We had feelings. And, I think it was eye-opening to all of us to say, look, there are things that we could do better. There are things that we might need to standardize in a way to do better. And yes, sleepiness is important. So the ASM did come out with the statement, a position statement earlier, saying that sleepiness is a clinically relevant outcome measure that needs to be considered for treatment of patients with sleep apnea.
So what is your hope for this tool, Fariha?
I feel like we're at a very interesting point in our field, right? We've done things a certain way just because we've always done them a certain way. But, we now have a task force that is reevaluating how we classify sleep disordered breathing by looking beyond the AHI. I think it's time for us to look beyond the Epworth, right? The Epworth has its uses, but this questionnaire provides longitudinal insights that I think will help us track the treatment of patients with sleep apnea. It should help us provide truly personalized care. And that's where we're going with all of this. As I said earlier, I think I'd really like to encourage researchers and clinicians to apply for the strategic research grants through the foundation, because the work that we do today will hopefully become the standard of care in the future.
Doug, what about you? What's your hope for this tool?
Well, I think that the tools that we have had, some of which have been harder to access than others, the point of any of the tools is really for the patient to be able to give a voice to their symptoms and for then the clinician to understand how well they are doing in managing that set of symptoms. And I think to this point, in sleep, we've been a little bit limited in what we've been able to formally assess over time. And so I think that this tool hopefully gives a better voice to that patient to say, hey, are you really managing all of my symptoms, that we think are related to sleep apnea? And it gives help to the clinician who can now maybe better assess some of those symptoms. And then hopefully it gives sort of notice to the payers and to the health systems that we work for that those patient-reported outcomes are valid and are important in that patient's care, right? I think for a long time, sleep has had to battle a little bit to say we are in fact a valid medical specialty. We're not just an offshoot. And I think this again shows the world a little bit that, we are managing a patient in a real way and changing their symptoms in a real way. And I think that that's an important message to send.
You know what I thought was kind of a subtle message a little bit was that question about, I found it difficult to concentrate, because I think then you are also linking those in the patient's mind that, oh, I've always thought my difficulty concentrating was because I have ADHD. Maybe sleep has something to do with it too. So I thought that was kind of interesting.
Yeah, there's a lot of subtleness to some of these questions. And Again, I think because some of them seem similar to us, to patients, they mean different things.
Yeah.
And I think it's important to get the patient perspective in this.
So any final thoughts for us?
Well, I think I'd like to thank our expert advisory panel, Chip Davies, Charlene Gamaldo, Carol Rosen, who did a massive amount of work on the end product of the paper. Fariha, obviously, who contributed years of both personal experience and board experience to it. And Shireen Thomas at the AASM, who really has shepherded this project along from its inception years ago.
Fariha, how about you?
Yeah, I totally agree with you, Doug. We are so very grateful to everyone for all their time and energy that they've put into this project. I realize that change is really hard. When we try to do updates in clinical practice, sometimes that takes time to implement. Sometimes it takes time to work in new processes. So this project we've been working on for a very long time, and I'm pleased that we're finally here and able to use this tool. We're hoping that with tools like this questionnaire, we're not just tracking sleep apnea, we are empowering patients and clinicians to see a fuller picture, monitor progress, and evaluate for meaningful change over time.
Oh, and I hope people are willing to try something new, right? To download this tool from MAPI. Yes, it takes a couple of clicks to get through that, but bring the tool down, try it in a couple of patients, or see what you think. I mean, I think our hope is that this becomes a standard, but to become a standard, it needs to be used. It needs to be out in the wild of clinic. And so our hope is that part of this podcast today is to encourage people to go to the AASM website, go to the MAPI website, get the tool and begin to use it so we can better understand maybe the ways in which it should really be used every day.
Well, thank you both for joining us today and helping us to better understand PLATO, the new longitudinal assessment tool for obstructive sleep apnea.
Thanks for having us on, Seema. We really appreciate it.
Thank you, Seema. This was a pleasure.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.